Hello, everyone. My name is Roxanne Chabot from RBC Consultants. Welcome to another SkinChat webinar. Today, we're going to be talking about the mature xerosis patients. We're going to review considerations and tips for epidermal barrier maintenance and quality of life. Our speakers today are Dr. Joachim Fleur, who's professor and head of the outpatient clinic for allergology, Institute of Allergology at the Charité University Hospital in Berlin, Germany. Also, our speaker today is Dr. Peter Buring, who's the professor, Department of Dermatology at the Aalborg University Hospital, Aalborg, Denmark. We'd like to thank our sponsor, CeraVe, for making this educational event possible. Before we begin, if you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. We greatly appreciate it if you could fill it in and send it back to us. And also within 1 to 2 days of the webinar, you will be receiving a certificate of attendance as well as the recording of this webinar. Again, if you'd like to submit the questions, please submit the questions in the question chat pane on the right-hand side of your screen. I wrote a little note in there so you can see exactly where you need to write your question. So without further ado, I will pass the floor virtually to Dr. Joachim Fleur.
Thank you, Roxanne, for the nice introduction. And I'm really happy to be here together with Peter, my friend. And we are doing this research on mature xerosis for the last 2 years or so, and I'm very happy that we have this webinar together today. First, I would like to put a little questions out to see the progress that you're making. Which factors potentially contribute to the xerosis? Please choose one of the 5: dietary disorders, dermatological diseases, internal diseases, like for example, diabetes, hormonal changes, or all the above mentioned factors. Please make your choice. And most of you selected all the above mentioned factors, which is the correct answer. And I will show you together with Peter which are these factors. The objective of our webinar today is to give you an update on understanding of unique aspects of mature xerosis and the epidermal barrier, discuss considerations and tips how to manage mature xerosis in the daily practice, and educating patients on restoring a healthy skin barrier. We would also like to discuss how to meet patients' needs for cleansers and moisturizers in treating mature xerosis, and ultimately, we would like to discuss with you how to explore the benefits of restoring a healthy skin barrier using skincare, specifically a ceramide-containing product. When we started this project, this journey, so to speak, we did a literature review for a publication on a consensus on mature xerosis, and the goal was to come up with patient considerations and practical tips for the epidermal barrier maintenance and quality of life. What do we know from the literature about skin barrier integrity in mature xerosis patients and the role of skincare, such as ceramide-containing skincare from the European perspective? We did this literature search, which was a structural search done on 1st of September 23 with specific search terms, especially mature skin xerosis and skin barrier physiology or function or dysfunction, and so on. And we found 78 hits in PubMed. We also looked into Google Scholar, and together we had to exclude a couple of them, and we ended up to look a little bit deeper in 56 publications, excluding the duplicates. Sorry, it's not moving. Okay, again, that was too fast. 93 selected, 56 included, 21 were clinical studies, and 35 reviews based on these 21 clinical studies. 12 were on skincare, 8 on barrier, and 1 on prevalence. And here are the first consideration and tips. Number 1 was the consideration was xerosis is common in mature patients due to the age-related skin barrier changes. Contributors to mature xerosis include intrinsic factors such as ethnicity and chronic conditions, extrinsic factors such as medications, climate, and overuse of heaters and air conditioners. And for this consideration, we agreed on the following tip: consider intrinsic and extrinsic factors when educating patients with mature xerosis on the underlying cause of their skin changes, the relevance of introducing a skincare routine, and the selection of products to optimize compliance and outcomes. Second consideration, studies have shown that age-related changes to the skin barrier, including reduction in the epidermal lipid synthesis, can reduce tartar corneum lipid content by more than 30% and impact subsequently the skin barrier permeability. Our tip was that product recommendation for restoring skin barrier function and improving skin conditions in mature xerosis should consider skin barrier function and needs. So focus on the skin barrier. Patients should be informed about the specific products to use, the frequency and the timing of application, sufficient coverage of the body, so also the amount that they have to use and the purpose of using these products for treatment and prevention. Third consideration was we should also consider racial and ethnic differences in the skin barrier, since they may contribute to the variations in prevalence and severity of atopic dermatitis, xerosis, and pruritus. Regional disparities in access to dermatology care may also impact the reported prevalence of these conditions. This is one of the biases in the studies that we looked into. Our tip was consider racial and ethnic variation in skin physiology, disparities in access to skincare, and individual cultural preferences when educating patients on skincare routines. So this was the first consideration, and here again the age-related skin barrier changes and the contributors. The aging population and the dermatological changes are today very prominent. Most people can expect to live into their 60s and beyond. So if you look into the age pyramid, it's no longer a pyramid. The upper part of this age pyramid is getting broader and broader, while the base is a little bit shrinking. So we have to take into account that the population that is taking care of the advance of the mature people is probably not sufficient to cover all the needs of the aging population. And every country and region in the world has experienced this growth, both in size and the proportion of older persons in the population. Aging beyond 50s calls several fundamental changes in the skin, with significant and widespread dermatological implications. Also, the amount of dermatologists that can treat and help this population will in the future be not sufficient. So we have to find ways to educate, like webinars, like we are doing today, also for lay people and for patients. Skin conditions affect up to 70% of aging populations, and the most common are xerosis-related pruritus. So we have the xerosis, the barrier disruption, the barrier dysfunction, and subsequently clinical signs as the pruritus. In subpopulations, we have very old mature people, like for example here, this Japanese lady with 124 years. And especially in Japan, in the Okinawa region, in Sardinia, Italy, that might be the good Italian wine, Nicoya, Costa Rica, Icaria, Greece, and Loma Linda in California are thousands of miles apart, but they share this this population that is very advanced in age. And the experts predict that the number of centenarians will continue to rise in the coming decades, while genetics play a fundamental large role in healthy aging. Physical activity, social support, the exposome, and where you live also can influence the chance of living a very long life. And I would like to add also the happiness in your life. If you're completely unhappy, it's very unlikely that you will join this lady in the centenarian club. Speaking of quality of life, this is a very important point that we have looked into reading the literature. It might be highly affected if you have a xerosis because it induces scratching that can lead secondary to infections and subsequently to ulceration and chronic wounds, which severely affects the quality of life. And the management of xerosis as one of the underlying causes, maintaining moist skin, a healthy skin barrier, are mandatory to prevent these complications. The moisturizers represent the mainstay of treatment for the xerosis and related pruritus in mature skin, including components that alleviate the pruritus. Here's some clinical pictures on the left hand on the lower leg. And you can see to some extent already scratch marks, but also on the heel, these cracks and fissures are frequently seen in elderly. Of course, as a dermatologist, we need to exclude here a fungal infection. So this mature xerosis, as I've shown you in the pictures, is a common condition. And we think that more than 50% of the individuals aged above 65 are affected. This has been shown in the study 1 and 2 that are cited below. If you advance further in age, for example, in study number 3, the care-dependent patients in this study had in 99% developed xerosis. However, the etiology of the sclerosis is not entirely understood, and we have to look carefully, even though the entire population over 80 probably present to some degree xerosis, what are the underlying internal and external genetic and environmental mechanisms that lead to this process, including keratinization and lipid content in the stratum corneum that might be affected. Mature xerosis is often associated, as I mentioned, with downstream effects like pruritus and involve mainly the lower extremities, also the arms, the upper extremities, and prominent during wintertime and humid conditions. What are the factors contributing to skins? In my question at the beginning, I asked you if you agree with internal diseases, and here we have mainly kidney diseases, but also diabetes, liver dysfunctions. We have chronic inflammatory bowel disease. We know that the microbiome, for example, of the skin talks to the microbiome of our digestive tract. Rheumatic disease, menopause, so everything that is related to hormones, pregnancy, andropause are related, and also myeloproliferative disorders, Hodgkin's disease. And if we go back to our dermatology practice, atopic dermatitis, of course, allergic contact dermatitis, irritant contact dermatitis, and the worst one, ichthyosis, but also infections like bacterial and fungal infections. Scabies, a terrible infection, very difficult to treat, and with a lot of xerosis in the after the treatment. So very often the harm that is done with the topical treatment is worse than the scabies themselves. And of course, lymphoma might also be a factor. Then we have the extrinsic factors that are medication related, and we all know the retinoids as a side effect. We have xerosis, but also a lot of the cardiac medication might have as a secondary side effect xerosis. And then we have the dietary disorders, insufficient fluid intake, which is the most common. We have excessive perspiration, hypervitaminosis as vitamin A and D, niacin deficiency, zinc and iron deficiency, which usually, if you have a normal nutrition are not present. But as we know, elderly people, they are not as mobile to make all their grocery shopping, or they live in remote areas. There you might see these dietary disorders related to Xerosis. If you have a look at the mature Xerosis that may lead to pruritus, here I have one of the stratum corneums represented. You have the lipids that are involved, but also other factors. If you have a disturbed stratum corneum, you have an increased susceptibility for irritants and allergens, and subsequently inflammation and downstream pruritus. In this study, 756 patients aged 65 and older were assessed in a cross-sectional study, and they reported the prevalence of 56%. 9 had a moderate to severe cirrhosis, which put a huge burden on the quality of life of these patients. In a second study, a huge cohort, again, 11,730 patients, 20% showed chronic pruritus in the age group of 60 to 70 years. So we also looked into the associated risk factors in these studies. And so aside the age, female sex, atopic dermatitis in the history, and concomitant treatment that might be inducing Xerosis have been shown. In elderly people, the most common skin disorders in this, or the symptom that they show, is the pruritus. They complain very often about the pruritus. And in the studies, we have a minimum of 11% of this population, but up to 78% of this elderly population show pruritus. Of course, as a physician, we have to exclude internal comorbidities like renal failure, cholestasis, systemic infections, diabetes, liver failure, malignancies, and some hematological disorders as shown before. And it's multifactorial, the Xerosis, the mature Xerosis. Both, and there are a couple of studies, not many, but some of them have shown that the quantity and the composition of lipids and the natural moisturizing factors in the stratum corneum are altered and are decreased in mature Xerosis. It's a little bit difficult to distinguish between the constitutional Xerosis and specific dermatosis per se, like atopic dermatitis. In aged people, psoriasis, usually the psoriasis starts early, so that's a little bit easier. And this Xerosis can also be triggered by exogenous factors, and it might be related or due to systemic diseases, as mentioned before. So going back to our panel survey, where we then looked into the tips and considerations, the mature Xerosis might be present in prior to 50 years of age or above, depending on the lifestyle factors. We all know this from our patients. If they have a very heavy lifestyle, like smoking a lot, early hormonal changes, like alcohol or other substance abuse, overuse of sun exposure, we see these Xerosis signs earlier than 50. This 5 of our 7 panelists agreed on this, and most patients with mature Xerosis will present them directly if they have access to dermatology with these symptoms of pruritus and dry skin. Our panel agreed that pruritus, flaking and scaling, erythema, and skin roughness were the most prominent symptoms. Other notable features were lichen simplex, discoid eczema, discoloration, fragile and thinned skin, especially when we have overuse of topical steroids. How can we improve the skin condition of mature Xerosis? Here again, we did a little internal survey, and we think, or we agreed, 5 out of 7, that appropriate counseling in a Xerosis patient on the prophylactic use of cleansers and moisturizers are useful. Again, 5 out of 7 agreed on the recommendation of a combination of a gentle cleanser, not harsh soap, but gentle cleanser, and subsequently or additionally the moisturizer, while 2 panelists recommended only gentle cleansers or only moisturizers. But at least one of these 2 components were recommended by all panelists. We all agreed on modification of lifestyle, such as short contact of showers with lukewarm water and daily sunscreen application when you live in areas and during the time of the year where you have strong sun exposure. At the moment, it's a gray, dark day here in Berlin, so probably you don't need sunscreen. But 2 months ago, we still had strong sun here, so I still recommended it in September, but now mid-November, you don't need it. Sunscreen SPF 50+ was recommended by 6 out of 7, while one of our colleagues indicated that according to the region, SPF 30 might be sufficient regarding your pigmentation protection and protection of the skin. So coming back to the risk factors, we already talked about the dermatological diseases, the internal diseases, we discussed them, and psychiatric disorders. Also, I mentioned the alcohol and drug abuse, anorexia is one of the, and tics like too often cleansing and washing. Here you see the xerosis mainly on the hands and the adjacent area. But also the extrinsic factors like climate, air conditioning, heating, overheating in the winter, as well as hot water bathing for a long time, using harsh soaps, tobacco use, sunbathing, and the cosmetic habits that are counterproductive, and also stress as a lifestyle or can be a risk factor for acute xerosis. And I mentioned before that the medication that you take, internal medication, and here diuretics are known, retinoids are known, a little bit less are known, lipid lowering. However, we thought at the beginning when they were introduced that we would see more of these side effects. And some of the contraceptive anti-androgens also are responsible for the underlying cause for xerosis. I mentioned the dietary disorders, and I will not go back into these. So if we put this together for general measures, and that's a chart that I have on my desk to explain the patients, the general measures can be easily taken by the patients themselves. Smooth clothing, healthy diet, not overheating your room, healthy lifestyle, and skin cleansing contact only with water or with a very mild cleanser. If you look into the specific areas here, we think that bathing for maximum 5 minutes, no bubble bath or lukewarm water or just a shower, and mild non-alkaline cleanser. Cotton clothing, avoid friction, avoid wool if you're sensitive to this. Here are some considerations and tips for food, especially if you have problems with food allergy. And the hands and feet are very important to keep the contact with soap and water, and maybe even disinfectants as short as possible, and use ultimately you might use protective gloves. And if you cleanse your skin not more than 2 times per day, and use skincare afterwards. So this one we mentioned, we have 2 of them. Now we come to consideration 2, and how does the skin change with aging? Here you have a smooth, young skin, and the epidermal atrophy is more prominent in aged skin, and we have a disorganization and loss of collagen fibers, as well as a reduced vascular tissue. So the dermal atrophy is also seen with this loss of collagen fibers, and the reactivity of the skin is negatively influenced with skin aging. Now I come to my favorite part, which is the epidermal barrier function. You see that the skin pH is in the middle. You have several factors leading to an acidic skin pH. And here in this part, you have the permeability barrier, which relies mainly on producing a correct mixture of lipids. And then you have other factors that influence mainly skin hydration, that the filaggrin, aquaporin 3, and sebum production. And then this leads to cutaneous inflammation, and ultimately you have this induction of pruritus and a vicious circle. This together is the stratum corneum barrier function, which is negative influence. And if you have this scratching cycle, you have ultimately also an induction of inflammation. This figure comes originally from work from the Peter Elias lab. And if you have an impaired barrier, sorry, this was too fast. Have an impaired barrier, you have a delayed wound healing, you have an increase of corneocyte retention in this part, and an increased susceptibility to bacterial and viral and fungal infections in this age group. So if we summarize this, you have for the barrier function, this can be measured with transepidermal water loss. You have in the infants up to 12 months, you have a fragile or a more susceptible barrier. On adults and especially on over 60s, there is not yet enough data that we have a complete consensus on the permeability on the basal level. For the skin pH, we know that within the first couple of weeks we develop the acidic pH, and then we know again that the skin surface pH rises again in elderly people over 70. So we have here a second factor. If you go back to my previous slides, pH, barrier, hydration. And ultimately, if you look at the morphology, we have a relatively consistent throughout life skin strata, and they are thinning over life due to the exogenous and endogenous aging. And also the desquamation, which is related with the kallikrein 5, formerly known as stratum corneum tryptic enzyme, is regulating the desquamation. And we see with aging a decrease in kallikrein 5, which leads to a reduced desquamation in senile xerosis. This is a study from Ruby Gadialis from the 90s of the last century, and she could show a decline in ceramide 1 linoleate with age with a clear drop after 50. Here she has a young group, this is a middle-aged group, and you have a significant decrease with age in this ceramide 1 linoleate. This is a study published from Farage and Miller and Howard Maybeck, and they could show that with age you have a loss in fatty acids, but also you have a loss in ceramide, which is the key, one of the key, or maybe the key player in the epidermal lipid. Not so much changes in the cholesterol, even though it still goes a little bit down. So to summarize these changes with mature skin, you have the keratinocyte renewal is slowed down and the apoptosis increased. That means the machinery is turning slower and is dying, the single cell is dying faster. We have a dysfunction in skin barrier, which leads to an increase in water loss. The number and function of sebaceous glands decrease, leading to xerosis because, for example, the glycerol in the stratum corneum comes from the sebaceous glands. So here you have the internal glycerol content decreased in mature xerosis, which results then downstream to more vulnerability in skin and pruritus. We also see a gradual degradation of skin innervation and heat imbalance. They are more susceptible to cold. That has been shown in a nice study. And if we go again to the pruritus, to the itch, this might cause scratching leading to secondary lesions, infections, excoriations, erosions, and chronic wounds. So here, this is a figure to demonstrate how this scratching-induced cycle in perturbating the transepidermal water loss, the barrier, which then allows allergens, pathogens, irritants to penetrate and to activate the proreceptors and lead to the itch. This vicious cycles is more prominent in mature xerosis. So to summarize my findings of the study and of our consensus meeting, mature xerosis is common, multifactorial, including intrinsic age-related changes, the use of medications, systemic conditions, and not only in the skin, like hyperthyroidism, and the overuse of heaters and air conditioners might lead to mature xerosis. Some studies have shown that the age-certain corneal demonstrated in more than 30% a reduction in total lipid content compared to young skin due to reduced epidermal lipid synthesis. Skin barrier differences between the racial and ethnic populations. I haven't shown you this study today, but this is a huge point of research interest now and may contribute to the variations in prevalence, severity, and AD, xerosis, and psoriasis. And with the climate changes, we have to take environmental issues into consideration. Disparities in access to skincare, depending on the area where you live and where your population is, may also play a role in these variations. And with this, I hand over to Peter. Peter, the stage is yours.
Thank you very much, Joachim, and thank you to Roxanne for inviting me. And I'm really happy to be here together with my friend Joachim to talk to you about mature xerosis. Let's see, I just have to take over the screen. Sorry, I'll move. Right, we have our second tip from this panel is that product recommendation for restoring skin barrier function and improving skin condition in mature xerosis should consider skin barrier function and needs. And patients should be informed about the specific products to use, the frequency and the timing of the application, sufficient coverage of the body, and the purpose of using these products for treatment and prevention. Just to recapitulate the skin barrier function, if we have a healthy skin, which can be compared to a brick wall with bricks and mortar in between. If the mortar, which is in the skin, lipids, if that doesn't work, there we will have a loss of water going through the barrier, and that will dry out the skin itself, meaning that we get crack because of the drying of the skin. And the defective skin barrier will also allow irritants and allergens to enter the skin and produce inflammation. And what can we do? We can use a moisturizer, and a moisturizer contains at least 3 different things. First of all, emollients that can smoothen the skin, which could be glycerin, oils, and butters. We use humectants that can hydrate the skin cells, could be urea or natural moisturizing factors. And then we need an occlusion on the top to trap the moisture so that it doesn't evaporate away from the skin. And that could be silicone oils or petrolatum. But we can improve this moisturizer even further if we add physiological lipids to actually restore the defective barrier function. And that could be, first of all, ceramides, could be cholesterol and free fatty acids as well. We've heard before environmental factors play a role, occupational factors play a role, and skin cleansing and washing is also very important in influencing xerosis and pruritus. And again, moisturizers have shown benefits in promoting healthy skin barrier structure and function of this xerotic skin. We have some considerations and tips for cleansers and moisturizers. First of all, these surfactants in cleansers should remove debris, oil, and makeup, but should not disrupt the skin barrier, because then we get erythema, inflammation, xerosis, and pruritus. So again, we can use hydrating and ceramide containing cleansers that can actually improve xerosis and patient comfort without disrupting the barrier itself. Moisturizers, an ideal moisturizer is safe, effective, cost-effective as well. It's free of fragrances and sensitizing agents. It should be pleasant and easy to use. It should last long, and it should be designed again to optimize the lipid and water content of the stratum corneum. And it's very, very important because adherence to skincare is key here. And we often see that poor adherence is due to incomplete or slow response of the therapy. We have problems with adverse effects such as skin irritation, too complicated and inconvenient regimens how to apply it, and also regimens that do not consider differences in cultural tradition or preferences. What can actually improve adherence is that, for example, less amount of products is needed, reduced frequency application, meaning long-lasting application here, incorporate skincare into the daily routine, making a habit, and select user-friendly products, and also educate both patient and caregiver so that they can work together. Again, here is a complete moisturizer. It has to include occlusive agents, humectants, emollients, essential ceramides to restore the barrier, and a system that can produce sustained release of the product. And to do that, we can use this multivesicular emulsion. These are small fatty emulsions that contain several layers inside each other, one layer being dissolved after the other, meaning that the application will be longer lasting, and we see a sustained release of the ingredients. And that is what you can see on this graph, where the two blue lines are showing the ceramide containing lotion and cream, while the others are just petrolatum standard moisturizers. So there is a much better effect using the ceramides here. I'm going to show you a couple of studies, and this is a double-blind intra-subject controlled split body study with 4 weeks twice daily treatment of either a ceramide containing moisturizer or a simple paraffin-based emollient to both forearms and lower legs. And what we see here is that the change in stratum corneum hydration from the baseline, which is 0 here, up to day 29. It's a little better here in the paraffin-based moisturizer, much better here in the ceramide containing moisturizer, and this is the age group from 18 to 39. In the middle age here, we also see a little effect of the paraffin-based moisturizer, a much better effect here of the ceramide. But in the elderly, we actually see a worsening in the hydration in the elderly with the paraffin-based, and that is actually a surprise to me that it could actually be worse after application of a moisturizer. But again, with the ceramide, it's much better here. And this is just showing, the other graph here is showing the water content, the absolute content. The further one here was the first one was the change. This is the absolute water content in the top 5 microns of the stratum corneum. Again, we can see a better content of water with the ceramide moisturizer. And this is again the erythema that happens after a 24 hours application of a soap patch on the skin, because that soap patch will produce irritation. And this irritation is actually seen as erythema. This is the visual score of redness, more redness with the paraffin-based moisturizer, less with the ceramide contain in all age groups. And here we see objectively measured with a measurement device showing exactly the same, less erythema with the ceramide treated skin. And again here, transepidermal water loss showing the defective barrier function. And there's a more water loss here with the paraffin-based moisturizer than compared to the ceramide. And that is especially important in the 60+ year of age. This is a more interesting way of looking at it, because this is a Fourier transform infrared spectroscopy. That means that this device can actually measure the composition of the lipid bilayer, and it can actually evaluate the quality of this barrier, because if the barrier is intact, the peak of this graph moves to the lower wavelength bands. You can see it's opposite, it goes up and down this way. And what we can see actually is that for all the age groups, we see a movement towards a better lipid structure with the ceramide containing moisturizer. We need a change. This in this study is a clinical study of a patient age 70+, 4 weeks of application of a ceramide containing cleanser and a moisturizer cream routine. 30 patients. These are the men, these are the women. Legs and feet are the main affected areas. These patients all had concomitant medical treatment, average of 2.4 drugs, mainly statins, calcium antagonists, diuretics, and antiplatelet agents. And that also contributed to problems. This is the clinician's evaluation of roughness and desquamation, which was reduced by 82%. Discomfort due to skin dryness, here 93%, and fissures decreased by 97%. And this is actually the patient's symptoms. They found that roughness and scaling resolved in half of the patients. Discomfort was no longer an issue for 8 out of 10 patients, and fissure resolved in almost all of them after this treatment. And these are just before and after pictures, clinical pictures, where you can easily see the effect of the treatment. And this is quality of life, and 77% of the subjects no longer felt embarrassed or awkward about their dry skin. 90% of the patients no longer felt their dry skin impacted their social or leisure activities. And 93% of the patients no longer felt their dry skin limited their daily activities like work and rest. There are not many studies on mature cirrhosis. These two actually shows the effect of it. This is a study from 2021 by La Caruba. That was a clinical evaluation of a 10% urea cream on pruritus and dermatoscopical evaluation. And at the end of the 2-week study, all scores showed improvement statistical significantly. And in the other study by Kim from 22, this was a treatment with a moisturizer and a mild cleanser. They looked at week 2. Again, the treatment group showed more improvement in total clinical score and the visual dryness score, as well as the itch quality of life. So our third consideration was that racial and ethnic differences in the skin barrier may contribute to variation in the prevalence and the severity of atopic dermatitis, cirrhosis, and pruritus, and regional disparities in the access to dermatological care may also impact the reported prevalence of these conditions. And again, we know that there are differences in the structure and function between Black, white, and Asian and indigenous populations. And if we look at that, especially African American skin has the lowest ceramide content. They had, because of that, a greater loss of water through the stratum corneum. And Caucasians were something intermediate ceramide content with intermediate loss of water through the stratum. And East Asian, despite they had a thinner stratum corneum, they had the highest ceramide content and the least amount of water loss through the barrier. Again, you can see here the content of ceramides in African American, Caucasians, and East Asians. Just a clinical picture showing mature cirrhosis in black skin, which looks different than in Caucasian skin. And because of cirrhosis, the patient with richly pigmented skin have a higher risk of developing the post-inflammatory dyspigmentation, and that can last for months to years. And it might also induce pruritus. Pruritus induces excoriation, and that might result in permanent depigmentation because of scratching. And again, some data also showed an increased transepidermal water loss and decreased ceramides in black skin, which actually leads to pruritus. So our third tip here is that we should consider racial and ethnic variation in skin physiology, disparities in access to care, and individual cultural preferences when we are educating patients on skincare routines and the product selection. And again, in our panel study here, we were asked in a pre-meeting survey, and 60% of us actually reported no changes in the recommendation for cirrhosis in richly pigmented skin phototypes. But those few who frequently treat patients with darker skin type, they recommended products with greater moisture retaining properties and petrolatum-like consistency in pigmented skin. So overall, the complete moisturizers, they should contain emollients to smooth, humectants to hydrate, physiological lipids to restore the skin barrier function, and occlusives to trap the barrier moisture. The summary here is that gentle cleansers and moisturizers are underused in mature cirrhosis. The challenges include, first of all, lack of awareness on maintaining a healthy skin barrier, a multitude of health issues, polypharmacy, variation in skin types and skin tones, culture, climate, barriers to access. The clinical studies support skin care for mature cirrhosis. They are mostly small and not always specifically on mature cirrhosis. Skincare is frequently lacking or overlooked as part of skin treatment for this mature population in order to reduce pruritus and promote a healthy skin barrier. Early emphasis on patient education and preference will instill lifelong moisturizing habits. And in the future, more robust multidisciplinary research is required to elucidate the key therapeutic avenues for mature cirrhosis patients. Thank you very much.
So remember, if you want to ask any question to our faculty, please write in your questions in the question chat pane on the right-hand side of your screen. Again, we'd like to thank our sponsor, CeraVe, for making this educational event possible. So we do have a couple of questions. The first question, what would be the optimal ingredient in a more modern moisturizer?
I think in a modern moisturizer, you need the standard ingredients, first of all, that we have seen for years, that are emollients, humectants, and barrier forming ingredients. But now we have evidence that also ceramides are so important so that we can actually restore the natural barrier so that the skin itself can actually act and work properly, not needing the moisturizer forever.
And I would
Another-
like to add also, we need some ingredients that support the natural moisturizing factor, like glycerol and other components that help to restore the hydration.
Another question that we have is from our audience. Dear colleagues, what are your thoughts about these category of patients where neither AD, ichthyosis, scabies, or anything else has been found? We sometimes have patients above the age of 70 with only mildly dry looking skin and itch, and all other causes have been ruled out to the best of our ability. Relevant to blood work, biopsy, rule out pre-bolus BP. Creams are simply not enough. We often need to augment treatment. What are your thoughts?
I might take this one. They might fall into the category of sensitive skin, and we know that sensitive skin is a small fiber neuropathy. So in these patients where the simple moisturizer or even the really good moisturizer is not sufficient, and we ruled out that they are overdoing their other hygiene like washing, sometimes I use in these patients, especially for the itch part, I use gabapentin. Which is designed for neuropathy. That's a medical treatment.
Joachim, can I ask you, have you ever used capsaicin cream for this condition?
I only use this if I have a very localized pain or itch.
Okay.
It's a very powerful tool, but it's only, you can only use it, I would say, up to a maximum of this size. And I use it quite often in post-xeric neuropathy or pain. And there it works very nicely.
Okay.
But if you have a generalized lower leg dryness associated with itch, it's too large,
Okay.
even for the cream.
Another question is the ethnic differences in transepidermal water loss show the least amount of transepidermal water loss in East Asian skin despite their thinner stratum corneum. What is the reason for this?
What we saw in these studies were actually that the East Asian skin type has the highest amount of ceramide, and despite the thinnest stratum corneum, they had the least evaporation through the epidermal barrier.
And maybe also an underlying reason might be that in many parts of Asia, the conscious of the negative effect of UV exposure is more prominent than in other parts. In our parts of the world, if you're very pale, you're still considered an unhealthy person, even though we know that protecting from the UV is crucial. But it's a cultural and educational problem.
Another question, can mature skin be divided into different age groups?
Peter, you mentioned that you had some insights into this.
Yeah, we saw these studies that I presented here. They were divided into different age groups, and the different age group actually reacted differently on the moisturizers containing ceramides and or petrolatum alone. And we saw the biggest difference in the age group above 60, where the ceramides had the greatest impact on the difference between ceramide containing moisturizer and the bland paraffin based moisturizer.
And I would like to add that we need more research in the mature skin per se. We need to find out what phenotype, what endotypes do we have. It's not only the age 60 to 65 or 75, it's the hormonal influence. We have to come up with a score for the exposome. We're just at the beginning to better understand mature skin. And I think the studies that we presented here and the expert panel are a first step, but we're just at the beginning of better understanding mature skin. So I think if we have the same seminar in 5 years, it will be completely different.
We'll do that.
And we will be different.
Have you addressed the problem of application?
Oh, that's really, somebody's putting his finger into the wound. Because in Denmark and in Germany, the same, and most of the Western countries that we oversee, we have the problem, especially in cities, we have the problem, I call it the loneliness of the aging person. The partner has died or they have separated from the partner. They don't live anymore in bigger families. They are not yet ready to go into a retirement home where they have assisted living. So they live by themselves and they can apply according to their mobility our great recommendation, great cleansers and wonderful moisturizers to the part that they can still reach. But the more they lose their mobility, the less they're unable to apply it in the areas that really matters. Lower leg, back, these are areas. So we have to come up and we have to ask our patients, are you living by yourself or can somebody help you with applying the cream? And maybe we have to ask our engineers to develop helps to apply the moisturizers even in the difficult areas.
There are some very interesting studies from Hans Christian Wulff's lab in Copenhagen looking at application of sunscreen cream. And that showed actually that when people apply a cream and then they looked at the sunscreen effect in ultraviolet light where you can easily see the application, it showed that there was a lot of skipped areas on the skin surface. So even though you're thinking you are actually applying the cream evenly over the skin, it shows that people cannot do it really. And that is why the recommendation for example, for sunscreen is 2 applications with 15 minutes between them in order to cover the whole area. If you only try and you cover 60% of it, it's not good enough.
Yes, we had in the 20 years ago, we had similar results from younger people in the work environment to apply protection creams. Studies that have been done by Peter Elsner and his group at the time.
I know him, yeah. But that it seems to be difficult to apply a cream evenly over the body surfaces.
And then a final question, a bit off topic, but perhaps you can help our member of the audience, is do you have any recommendations with chemotherapy and radiation care?
So for radiation, to prevent radiation dermatitis, there have been a lot of attempts with moisturizers, with steroids. What helped a little bit were antioxidant creams. But there is still something to do, and I know from several companies that try to help to improve this, but we can alleviate some of the symptoms, but at the moment for prevention of, especially in radiation, it's a little bit different for chemotherapy. There we know much more and we can be more helpful. We have to be at the side of these chemotherapy patients from the first day on. If they only see us when they already start to have their eczema or their acne-like lesions, then it's a little bit difficult. But if we help them from early on with moisturizer creams, with some antiseptic applications when we see an increase in folliculitis, then we are more successful. What are your experience, Peter?
Yeah, my experience is that actually ceramide containing moisturizer seems to work very, very well, especially as you said, people start before they start the chemotherapy so that the skin is healthy from the start.
Okay, so that is the time we have together. Thank you so much, Professor Fleur and Buren, for such an insightful presentation, clinically relevant. I'm sure it's helped a lot, all the members of the audience, and we'd like to thank you all for joining us today. Goodbye, everybody.
Bye-bye.
Bye-bye.
Stay
Thank you.
healthy.